Welcome. The following presentation from Answers in CME is part of an educational activity titled The Next Wave of CAR-T Innovation for Relapse Refractory Multiple Myeloma: Insights into Emerging GPRC5D-Directed CAR-T Cell Therapies. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported through an educational grant from Bristol Myers Squibb.
Hi, my name is Karina Patel, and I am an associate professor at MD Anderson Cancer Center in Houston, Texas, where I serve as the myeloma section chief and the director of myeloma clinical research. So today, we'll discuss emerging GPRC5D-directed CAR T-cell therapies in relapse refractory myeloma, focusing on the rationale for targeting GPRC5D and the key early clinical data that comes along with those studies. We'll also explore how these therapies may fit into the evolving treatment landscape. In this first session, let's discuss unmet needs in relapse refractory myeloma treatment that prompt the investigation of novel agents such as GPRC5D CAR T-cell therapies. So in myeloma, we have had a plethora of new treatments. We have been really lucky that we've learned that T-cell therapies have really improved outcomes for our patients. So currently in the NCCN guidelines, what's approved right now in patients that have had 1 to 3 prior lines of therapy are really the anti-BCMA CAR T-cell therapies, so both ide-cel and cilta-cel. And then in those patients who have had 4 or more prior lines of therapy, this is where we have our bispecific antibodies. Both are anti-BCMA bispecifics, such as teclistamab, elranatamab, linvoseltamab, as well as our anti-GPRC5D bispecific antibody, talquetamab. However, even with all these wonderful new therapies, why do we really need novel therapies? Again, those approved CAR T-cell therapies and bispecific antibodies have shown deep and durable responses in our patients with relapse refractory myeloma. However, the majority of our patients still relapse after standard therapy. And then triple-class refractory and quadruple-class exposed patients have even fewer options after that anti-BCMA therapy. So with those unmet needs with our T-cell redirecting therapies right now, prior exposure to anti-BCMA therapies earlier in that treatment reduces their effectiveness in subsequent lines. So treatment with GPRC5D and BCMA-targeted bispecific antibodies increases infection risks and the need for ongoing injections. So again, mechanism of action can really affect both safety and efficacy in terms of what is the next line of therapy and how will it work. This emphasizes the need for new therapies with novel mechanism of action, especially ones that help patients have improved quality of life. So in summary, patients with triple-class refractory and quadruple-class exposed relapse refractory myeloma really do face limited treatment options and poor long-term outcomes, underscoring a persistent unmet clinical need. This therapeutic gap has driven interest in novel targets and mechanisms, setting the stage for emerging approaches such as GPRC5D-directed CAR T-cell therapies that really offer a one-and-done approach. In the next session, let's discuss how GPRC5D-directed CAR T-cell therapies may address these unmet needs. So in this session, let's discuss how GPRC5D-directed CAR T-cell therapies may address treatment needs in patients with relapse refractory multiple myeloma. So GPRC5D is the G protein-coupled receptor class C group 5 member D. This is an orphan G protein-coupled receptor that's expressed on plasma cells. However, it's also expressed on skin, nail, tongue, and hair tissues. This is also expressed most strongly on multiple myeloma cells, so aberrant plasma cells, and it has minimal expression on normal plasma cells and healthy tissues. Hence, we think that this leads to improved profile for infections compared to BCMA therapies. With BCMA, there's a lot broader expression profile on both abnormal plasma cells, which are myeloma cells, but also normal plasma cells. Therefore, we see increased hypogammaglobulinemia with BCMA therapies, as well as increased infections. So due to this selective expression, GPRC5D is a validated target in multiple myeloma. So how could GPRC5D CAR T-cell therapies overcome challenges with BCMA CAR T-cell therapies? So expression patterns are independent of those of BCMA, which is really important. Patients who have had prior BCMA therapy, especially now in early line, GPRC5D CAR T-cell therapies can offer distinct clinical targets for those patients after relapse. We do know that there are mutations that happen with prior BCMA therapy or even loss of BCMA once patients have had one mechanism of action targeting BCMA. So we do need novel therapies. And also GPRC5D expression is unaffected by BCMA BCMA loss. So if someone had a prior BCMA therapy and had either mutations or loss, a GPRC5D therapy could still be very effective in treating those patients after that BCMA failure. So this really supports activity in BCMA exposed and BCMA refractory patients. So currently, there are a few different GPRC5D targeted CAR T-cell therapies under investigation in patients with relapsed refractory multiple myeloma. So we have arlocaptogene autoleucel, we have MCAR-H109, we have the OriCAR-017, and we have the CT-071. These CAR Ts offer a one-and-done approach, relatively different to our current bispecific, such as talquetamab. And what we've noticed relative to the bispecific, we've actually seen a lot less high-grade skin and oral toxicity, as well as resolution of these symptoms occur much sooner. So in summary, GPRC5D is a validated and selective therapeutic target in myeloma with potential clinical activity in BCMA-exposed and BCMA-refractory patients and enables effective treatment after BCMA failure. In the next session, let's discuss emerging efficacy data on GPRC5D-targeted CAR T-cell therapies currently under investigation in patients with heavily pretreated relapsed refractory multiple myeloma. In this session, let's discuss emerging efficacy data on GPRC5D targeted CAR T-cell therapies in patients with heavily pretreated relapsed refractory myeloma. Arlo-cel was investigated in a single-arm phase 1 dose escalation study in patients with heavily pretreated myeloma, including in patients with prior BCMA therapy, where patients received 2 different doses of CAR T-cells after lymphodepletion therapy. After a median follow-up of approximately 23.6 months in the overall efficacy evaluable population, Arlo-cel showed high and durable response rates with overall response rates of 91 and 92% and complete response rates of 44 to 58% across dose levels. Responses were also long-lasting, with median duration of response exceeding 14 to 16 months and median PFS at 14 months. Median follow-up was 14.5 months. Here is a summary of ongoing trials with Arlo-cel. The phase 2 single-arm quintessential trial in patients with relapsed refractory multiple myeloma with greater than or equal to 3 prior lines of therapy has a primary endpoint of best overall response. We're really excited about this study because hopefully this will lead to future approvals for a standard of care in the first CAR T GPRC5D-directed therapy. Then there's a randomized phase 3 quintessential 2 trial, which is comparing Arlo-cel versus standard of care regimens in patients with relapsed refractory myeloma after 1 to 3 prior lines, and for those patients who have had prior lenalidomide exposure. The primary endpoint here is PFS and MRD negative CRs. This trial is really important because it's being done in earlier lines of therapy. As our patients are getting novel treatments earlier and earlier, including first and second line for BCMA therapies, the need for novel treatments and novel mechanism of action is really important. Finally, in addition, we have a phase 1 study that is evaluating Arlo-cel in combination with mezigdomide in a heavily pretreated patient population. In our relapse refractory patients, having a different mechanism of action with CAR T-cell therapy could really help both overall response rates, but also duration of response and progression-free survival. In the phase 1 study of MCAR-H109 in patients with relapsed refractory myeloma with greater than 3 prior lines of therapy, treatment demonstrated meaningful clinical activity with deep responses observed in a substantial proportion of patients, including high rates of PR and MRD undetectability. Responses were also seen in patients previously treated with BCMA-directed therapy, suggesting activity in a BCMA-exposed population. The median duration of response was about 8.6 months at a median follow-up of 37 months. A phase 1 trial is evaluating concurrent administration of MCAR-H109 and anti-BCMA CAR T-cell therapy in patients with heavily pretreated relapsed refractory myeloma. In a first-in-human phase 1 trial, OriCAR-017 and CT-071 have demonstrated rapid, deep, and potent anti-myeloma activity with high rates of complete response and MRD negativity in patients with relapsed refractory myeloma. These have been done in a smaller number of patients, but we are excited to see continued clinical development over time. So in summary, emerging GPRC5D CAR T-cell therapies are showing preliminary signals of deep and durable responses, including in patients with prior BCMA therapy. In the next session, let us discuss emerging safety profiles of these GPRC5D CAR T-cell therapies. In this session, let us discuss emerging safety profiles of these GPRC5D CAR T-cell therapies. So common AEs to all CAR T-cell therapies include cytokine release syndrome. Of course, there's neurotoxicities such as ICANS, However, GPRC5D CAR-Ts have mostly low-grade CRS and ICANS. In terms of management, we tend to use acetaminophen or tocilizumab for grade 1-2 CRS. If there's higher grade CRS, steroids as well as vasopressor support may be needed. Neurotoxicities, including ICANS, again, usually the treatment of choice is corticosteroids. Another common AE is cytopenias. These are actually the most common treatment emergent AEs. And of course, something that our patients always are at risk for are infections. And again, because this is one and done, and we do provide supportive therapy such as GCSF for low counts, as well as prophylaxis and IVIG for hypogammaglobulinemia. There's a very low incidence of significant serious infections. So AEs that are unique to GPRC5D therapies include some skin-related toxicities such as rash, also potentially nail toxicities, and oral toxicities such as dyschezia and taste-related changes. Thankfully, with our CAR-Ts, we don't see oral toxicities that lead to significant weight change versus with a bispecific having continuous therapy. Some patients may have to stop treatment because of the significant weight loss. In terms of management, for skin and nail-related toxicities, we use supportive care such as emollients and topical oral steroids. With oral toxicities and dyschezia, we also have supportive care to help decrease that risk of taste loss. If patients do get dyschezia, our main goal is to maintain caloric intake. Another therapy-related toxicity is cerebellar toxicity independent of ICANS. This is rare but could be expected, and symptoms include dizziness, ataxia, and gait disturbance. We've actually seen this in some patients on prolonged bispecific therapy for GPRC5D as well. There's a potential to achieve lower rates of hypogammaglobulinemia compared to anti-BCMA therapies. And again, because normal plasma cells tend to not have GPRC5D. And there's a lower incidence of infections compared to anti-BCMA therapies for this reason. In the next session, let's discuss how GPRC5D CAR-T cell therapies may be integrated into future treatment algorithms in relapsed refractory multiple myeloma. In this session, let's discuss how emerging GPRC5D CAR-T cell therapies, as they become available, may be integrated into future treatment algorithms in relapsed refractory multiple myeloma. So in our trials, the key eligibility criteria require that participants must have greater than or equal to 3 prior lines of therapy, including an anti-CD38 monoclonal antibody, an immune modulatory drug, or IMiD, a proteasome inhibitor, and an anti-BCMA therapy. Patients also had to have adequate organ function and ECOG performance status of 0 or 1. Patients, of course, both in clinical trials and in the real world, cannot have active systemic infections prior to their cell infusion. The phase 3 trial is also evaluating GPRC5D CAR-Ts in patients with 1 to 3 prior lines of therapy and patients who have had LEN exposure. Again, the patients in earlier lines have bridging therapy that tends to work much better. So again, hopefully we will see how just going earlier in the lines of therapy will improve outcomes for GPRC5D CAR-T therapies. I do believe that patients on clinical trial tend to have more disease that is controlled rather than standard of care, where we are allowed to give holding therapy or we don't have to have IMWG criteria prior to actual cell infusion. So again, clinical trials are very limited in how we can treat those patients before we get cell therapy, but it is much easier in the real world to keep patients controlled before they go on to their CAR-Ts. Future considerations on how GPRC5D targeted therapies will be integrated include initially those post-anti-BCMA therapy patients. These are patients with the most unmet needs and limited treatment option. Alternative target in BCMA loss or resistance, because again, we do have other mechanism of actions that go after BCMA, but there is data that shows that some patients will have BCMA mutations or loss, that the next BCMA therapy might not work as well. So having a different target is very important. Combination strategies to mitigate antigen escape, such as with BCMA CAR-T or CELMoDs, are very, very important to really improve outcomes for our high-risk patients, but also our patients who may not have T cells that are as active or may have other resistance mechanisms with expression of BCMA not being on all clones of the myeloma. Potentially, there's a lower rate of CRS and ICANS versus BCMA CAR-T therapy, which could inform risk-benefit decisions. And GPRC5D CAR-Ts versus bispecific selection could be guided by frailty, disease burden, and access to care. Patients getting a one and done tend to have better long-term quality of life and return to sort of normalcy, as my patients tell me, where they don't have to keep coming in for treatments. So in summary, GPRC5D CAR T cell therapies have emerged as an important non-BCMA therapeutic target in relapsed refractory multiple myeloma that expands the treatment armamentarium beyond BCMA-directed therapies. This really addresses unmet needs in heavily pretreated disease, but preliminary data shows encouraging efficacy and manageable safety, potentially in early lines of therapy as well. Further data from ongoing and future trials will clarify how these therapies may fit into the treatment paradigm as they become available.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.